Welcome you all to my today's class on hypertension. Hope you are all in good health and free from COVID-19 infection. Hypertension. Raised blood pressure is directly proportional to the development of stroke and coronary artery disease. So, control of blood pressure is very important. Definition. Persistent elevation of blood pressure more than 140 by 90 millimeter of mercury is called hypertension. We know the normal blood pressure systolic is 110 to 140 millimeter of mercury and diastolic is 60 to 90 millimeter of mercury. What we mean by persistent elevation of blood pressure? Persistent elevation means blood pressure should be more than 140 by 90 millimeter of mercury in 3 consecutive days in 3 separate occasions. Then we shall call it, that is, persistent elevation of blood pressure has occurred, and we shall then diagnose the patient is suffering from hypertension. I have taken some pictures from the Davidson medicine and hope you all have Davidson medicine, and you will find it in this book, textbook of medicine. British Hypertensive Society has given some definition and classification of hypertension. Optimal blood pressure, it should be for each and everybody 120/80 millimeter of mercury or below this. Normal, it must be below 130 and 85 millimeter of mercury. High normal, that is 130 to 139 systolic, and diastolic 85 to 89 millimeter of mercury. And in case of hypertension, there are 3 grades, 1 to 3, that is mild, moderate, and severe. Grade 1, that is mild, systolic 140 to 150 millimeter of mercury, and diastolic 90 to 90 millimeter of mercury. Grade 2, moderate, systolic 160 to 179 millimeter of mercury, and diastolic 100 to 109 millimeter of mercury. And grade 3, that is severe hypertension at or more than 180 millimeter of mercury, and diastolic more than 110 millimeter of mercury. Isolated systolic hypertension. It most commonly seen in the older age group above the age of 60 or 70. Grade 1 isolated, so only systolic 140 to 150 59 millimeter of mercury, and grade 2 160 or more. Now, causes of hypertension. 95% of cases, no underlying cause is found. So it is called essential hypertension. And 5% cases, there are some causes, and it is called secondary hypertension. Now, the causes of secondary hypertension. I have also taken it from the Davidson medicine. Alcohol, it is a bit less common in our country. Obesity, this is very important, and it has become predominant in our country also. Obesity, that is mainly central obesity. Pregnancy, that is pregnancy-induced hypertension. Renal disease, parenchymal renal disease, most commonly glomerulonephritis, and that is acute glomerulonephritis or chronic glomerulonephritis. Renal vascular disease, most commonly renal artery stenosis. Polycystic kidney disease. Endocrine cause, pheochromocytoma, sudden flushing, tachycardia, and high rise of BP. And after a few minutes, the blood pressure again becomes settled. Pheochromocytoma, Cushing syndrome, primary hyperaldosteronism, that is Cohn's syndrome, hyperparathyroidism, acromegaly, primary hypothyroidism, and thyrotoxicosis. And in our country, thyroid cause is mostly predominant. Drugs, steroid, NSAID, oral contraceptive pill, these are the responsible for the secondary cause of hypertension. And in the heart, one congenital cause, that is coarctation of the aorta. Clinical features of hypertension. Hypertension is usually asymptomatic. Among hypertension, usually diagnosed incidentally. Patient has come due to any cause to your chamber and you have measured the blood pressure and ultimately you have diagnosed in 2 or 3 settings the patient is suffering from hypertension. Or patient has taken admission in the ward, medicine ward, with some complications of hypertension and you have measured the blood pressure and found the pressure is severe. Sometimes patient present with complications like left ventricular failure, cerebrovascular disease, coronary artery disease, or some other complication which I'll discuss later on. So clinical feature, regarding clinical feature, you will say the hypertension is usually asymptomatic mainly. There are some target organ can be damaged by the uncontrolled hypertension and patient may present to you with this complication. There are main 5 organs targeted by the hypertension. Number one is brain, that is cerebrovascular disease, stroke, eye, retinopathy, hypertensive retinopathy, heart, that is left ventricular failure, myocardial ischemia or infarction, kidney, that is chronic renal failure, and peripheral vessels, mainly vessels of the lower limb, peripheral vascular disease. So these are the 5 target organ of the hypertension. You will remember it very nicely. Brain, stroke, eye, retinopathy, heart, left ventricular failure, or myocardial ischemia, or infarction, kidney, chronic kidney disease, peripheral vessels, peripheral vascular disease. Now, this is very important, how you will measure blood pressure. I have also, this is also taken from the Davidson medicine. Use a machine that has been validated, well maintained and properly calibrated. You have to see the indicating point is in the zero. So if you do not take care of the machine, it will give you false reading. Measure sitting BP routinely. If a patient come to you in your chamber or hospital setting, you will try to measure the blood pressure in sitting position. The patient who cannot sit, you will measure it in lying condition. So sitting BP routinely with additional standing BP in elderly and diabetic patient to exclude postural hypertension. Postural hypertension you have to measure in this group. Remove tight clothing from the arm, support the arm at the level of the heart. It is very easy to sit the patient in a chair and kept his hand in the table. That is, it is the same level with the heart. Use a cup of appropriate size. The bladder must encompass more than 2/3 of the arm. Lower the blood pressure very slowly, 2 millimeter per second. Read the BP at the nearest 2 millimeter of mercury. Use phase 5 disappearance of sounds to measure the diastolic BP. Take 2 measurements at each visit. You will commonly see in your internal life in the ward, the patient has come, patient is very anxious, attendants are very anxious, and you measure the BP, you may get it high BP. But you take another measurement at least after 5 minutes. Majority of cases, you will found the second measurement is almost normal. So you have to take 2 measurements at each visit, and especially if first measurement you found it is high. it in your chamber or in the hospital setting. Investigations. If you diagnose a patient as hypertension, then some baseline investigation is required to see any complications or any other comorbidity. So this has been described in textbook as objectives of investigation. Number one objective, confirm the diagnosis by obtaining accurate representative BP measurement. Representative means you cannot say a patient by a single measurement that is you are hypertensive. You identify any underlying cause, assess other risk factors and mainly cardiovascular risk, detect any complications if already present, and identify comorbidity. So these are the objectives of investigation. What are the baseline investigation we shall do for all patients diagnosed as hypertension? Urine routine exam for blood, protein, and glucose. Usually, normal urine does not contain blood. If there is RBC, it indicates there is something problem in the glomerular basement membrane. Patient may suffer from glomerulonephritis. Normal urine contain very trace amount protein. If there is mild, moderate, or severe proteinuria, it indicates underlying renal disease. Glucose. Glucose indicates patient may suffer from diabetes mellitus also, as because frequently hypertension is associated with diabetes mellitus. Blood urea, electrolyte, and creatinine, mainly renal function test. It is called baseline renal function test. As any complication has occurred or it is secondary to renal disease. Blood glucose. It is mandatory for all patients for to see the glucose status of the patient. Patient may suffer from the diabetes mellitus also. Serum total and HDL cholesterol, or you can say here the fasting lipid profile. Fasting lipid profile contains four components. One, serum total cholesterol, high density lipoprotein, low density lipoprotein, and triglyceride. And it should be done in the fasting state at least 8-hour fast. So best is overnight fast, and patient will give the blood sample early in the morning before breakfast. Thyroid function test. Thyroid function test is usually done all patients of hypertension is because among the endocrine secondary causes of hypertension, thyroid is the most common. So serum free T3, T free T4, and serum thyroid stimulating hormone. 12 lead ECG. ECG is baseline investigation for any hypertensive patient. Mainly, we see here the most common left ventricular hypertrophy. The most common complication of hypertension over heart is left ventricular hypertrophy, and any T or ST changes for coronary artery disease. So these are our baseline investigation for hypertensive patient. Again, urine routine exam for blood, protein, and glucose. Blood protein mainly for the underlying renal disease and glucose for diabetes mellitus. Blood urea, electrolyte, creatinine for renal function test, blood glucose, serum total and HDL cholesterol or fasting lipid profile, thyroid function test, and 12 lead ECG. Specialized investigation of hypertension. If we found anything during our examination, clinical examination, or in the baseline investigation, that there may be underlying other diseases or complication of or comorbidity, then specialized investigation is done in case of hypertension. This is not routine or baseline investigation. X-ray chest. X-ray chest mainly to detect the cardiac size. Heart size is best seen in the X-ray test view. If we found there is in ECG, there is left ventricular hypertrophy, we should go for X-ray test to detect any cardiomegaly. Heart failure, there is, we can see the heart size, we may see the lung base is congested, hilar area is congested, coarctation of area aorta can be seen in the X-ray test. Ambulatory BP recording. Ambulatory BP recording means the patient will record blood pressure in their home other than the doctor's chamber or hospital setting. Yes, because some patients become very much anxious in doctor's chamber, and there is sometimes transient elevation of the blood pressure occurs. This is called white coat hypertension. So ambulatory BP, patient will measure according to your advice in his or her home setting, and they will inform you the result of this BP recording, and it will help you to determine hypertension or white coat hypertension. Echocardiogram is indicated if ECG shows there is left ventricular hypertrophy and X-ray test shows there is cardiomegaly or features of heart failure, then you will go for echocardiogram. Renal ultrasound to detect possible renal disease. How we can assess possible renal disease in renal ultrasound? In case of renal artery stenosis, there is asymmetrical kidney size. The kidney size normal 7 to 11 centimeter, 7 to 11 centimeter, and it is nicely detected by the ultrasound. If there is renal artery stenosis in one side, the affected side kidney size will be decreased. So this is called asymmetrical kidney in case of renal artery stenosis. In case of CKD, there is continuous inflammatory process in the kidney. So there is some fibrosis also. So corticomedullary differentiation is lost. Cortex and medulla easily separated by the ultrasound. But in case of CKD, this differentiation will be lost. Then ultrasonographer will inform you that corticomedullary differentiation has been lost. Kidney size, due to chronic fibrosis, there is kidney size is gradually diminished in chronic kidney disease. So renal ultrasound is very, very important to detect possible renal disease. Renal angiography. If you found there is asymmetrical kidney ultrasound, that is, you are suspecting there may be renal artery stenosis, then you will go for renal angiography to detect or confirm the presence of renal artery stenosis. Or clinically, during examination, you have found the abdominal bruit in the renal area in any site, it is indicative of renal artery stenosis, then you will go for renal angiography. Urinary catecholamines to detect possible pheochromocytoma. If history is suggestive or goes in favor of pheochromocytoma, then you will do this urinary catecholamines. If you suspect the patient may suffering from Cushing syndrome for his or her appearance, Cushing-white face, or etc., you can go for urinary cortisol and dexamethasone suppression test. Plasma renin activity and aldosterone to detect possible primary aldosteronism. So these are the specialized investigation of hypertension. You will always remember that you cannot do this specialized investigation for all patients. If you suspect clinically there is some underlying disease, comorbidity, or to exclude secondary cause of hypertension, and your baseline investigation has given some clue there may be some underlying cause or comorbidity, then we'll go for specialized investigation for hypertension. Now you have diagnosed a person as a case of hypertension. Then how you will manage. It is also important for your family. Uh, Family members, especially your parents, may also suffer from hypertension. So you have to treat your parents first. There is two type of management. One is non-drug therapy, another is drug therapy. What is non-drug therapy? Non-drug therapy is equally important as drug therapy. Non-drug therapy means there are some lifestyle modification you need to for the management of hypertension and to prevent the complications of hypertension. Number one, body weight. If patient is overweight, he have to reduce the weight. Dietary history. Dietary history should be green leafy vegetable, more importantly, fresh fruit, and low carbohydrate diet. Low carbohydrate diet. Regular exercise, at least 30 minutes per day. At least 30 minutes per day and 5 days in a week. It is at least. It will prevent the cardiovascular complication. Only 30 minutes walking per day. At least 5 days or 150 minutes in a week. Salt consumption. If the patient is taking excess salt from you have discovered from his history, then you have to advise to decrease the salt consumption. What amount salt we usually take? The salt which makes our normal food palatable. It is normal for us. So patient will take normal salt required for the palatable food is normal. Drug therapy. There are so many classes of drug available, and you have to choose the drug according to patient age, sex, comorbidity, or complication already has developed. We shall discuss in the later slide. First, the thiazide diuretics, thiazides. These two names I have mentioned here, hydrochlorothiazide, indapamide. Thiazide diuretics are very, very important for treating isolated systolic hypertension. Isolated systolic hypertension. Only complications of hydrochlorothiazide or indapamide is electrolyte imbalance. Electrolyte imbalance, the main complication of or adverse effect of hydrochlorothiazide or indapamide is electrolyte. Otherwise, hydrochlorothiazide is very much cheap and patient cost is very important for selection of antihypertensive drug. There almost all of our patients are low socioeconomic condition, came from the low socioeconomic condition. So cost of the drug is very, very important. Hydrochlorothiazide, 25 milligram tablet available in our country and price is hardly 1 taka. Indapamide a bit costly. So hydrochlorothiazide is very, very cheap. The most important drug is ACE inhibitor, angiotensin converting enzyme inhibitors. These are and ARB, angiotensin receptor blockers. Both are the um, evolutionary discovery or invention of uh, antihypertensive drug. Their main advantage they causes cardiac remodeling of the myocardial cell. So, so it is, and also they have renoprotective effect. That is, in case of hypertension, there is proteinuria, and both of these drugs helps to decrease the proteinuria by decreasing the intraglomerular pressure. So, the AC inhibitor and ARB is the very, very uh, beneficial drug for all age group. Some AC inhibitors, enalapril, ramipril, captopril, olapril, lisinopril, their main adverse effect is fast dose hypertension, if especially used with the diuretics like high ceiling diuretics like furosemide. Another adverse effect of AC inhibitor mainly is dry cough. ARB, losartan, valsartan, there are so many ARB, but I should mention only two names for you: ARB, angiotensin receptor blocker, losartan and valsartan. Their dry cough adverse effect is very, very minimum. Calcium channel blockers. Calcium channel blockers, another important group of drug and highly potent. They are also mainly affects the isolated systolic hypertension. So they are the drug of choice like hydrochlorothiazide in case of older age group. Calcium channel blockers are two types. One is non-rate limiting, amlodipine, nifedipine, nicardipine. Rate limiting calcium channel blocker, verapamil, diltiazem. Verapamil and diltiazem rate limiting means cardiac rate limiting. So they are most commonly used in the various types of arrhythmia, hypertension with arrhythmia. Adverse effect of calcium channel blockers. They are highly potent and their cost is also reasonable. So we can easily prescribe. But main adverse effect of calcium channel blockers are ankle edema, but it is benign. But it may produce severe anxiousness in patients. So if patient develop peripheral edema, especially ankle edema by calcium channel blocker, you have to remove it. Beta blockers, atenolol, bisoprolol, metoprolol. Beta blockers, they have also antiarrhythmic effect also. Beta blockers are very much good, potent antihypertensive. They are their price is reasonable, but there are some things you have to do before prescribing beta blockers. Number one, you have to take history from the patient. If the patient has any kind of obstructive airway disease like asthma or COPD, it is highly contraindicated. You should not prescribe atenolol, bisoprolol, or metoprolol in case of beta blockers in case of patients suffering from obstructive airway disease, mainly asthma. Pregnancy, it decreases the fetal heart rate also, so it may produce problem. You have to calculate the pulse of the patient. If you found the patient pulse already low, so you should not prescribe the beta blocker. If the patient is suffering from complete heart block, you cannot prescribe beta blocker. If the patient is suffering from uh, acute heart failure, it is contraindicated. But in case of chronic heart failure, you may cautiously use mainly the bisoprolol and metoprolol. You can cautiously use in case of chronic heart failure. But in case of undergraduate level, our is in case of acute heart failure, it is contraindicated. We should remember this. Combined beta and alpha blockers are now available in our market. That is levitalol, carbidiolol, all are present. They are also very much beneficial. Levitalol is found in the injectable form, so it is very much useful for use in the eclampsia or pre-eclamptic patient, eclamptic or pre-eclamptic patient. Vasodilators, highly potent drug, arteriolar vasodilation, that is prazosin. Now, what are the initial uh, things you have to think in your mind? How you will choose of antihypertensive drug? There are so many antihypertensive drug available and so many classes of antidrivers. No one is unique. So you have to select for every patient individually. Choice of antihypertensive includes number one is efficacy. It should be highly efficacy. Its side effects should be less, as because hypertension is lifelong and he have to take that drug for till death. So side effects should be minimum comorbidity. This patient may suffer from diabetes, patient may suffer from heart failure, patient may suffer from any endocrine disease or renal disease. So comorbidity change the choice of the drug. And finally, cost. Cost is very, very important for our country. Almost all the patients will come to your chamber on hospital from low socioeconomic status. So you should prescribe, cannot prescribe a highly costly drug he or she have to take for lifelong. So she or she will discontinue it after a few days. So cost is very, very important. You will try always. This cost should be low, adverse effect should be minimum, but it should be highly effective. So this is called compelling indication of antihypertensive. That is, patient condition will compel you to select this drug. So this is called compelling indication of antihypertensive. So there are so many antihypertensive drugs and many classes of antihypertensive drugs are available. So you will, I have taken this picture also from the Davidson medicine, how you will choose the antihypertensive drug. ACE inhibitors, that is all prils, ramipril, lisinopril, and enalapril. The compelling indication, heart failure, we have told that it has cardiac remodeling property, so it increases the myocardial force of contraction and it also decreases the hypertrophy that has occurred in myocardium. So this is the drug in case of heart failure, we know anyhow. Heart failure due to any cause decrease the myocardial force of contractility. So this ACE inhibitor will remodel the cardiac myocardium and increase the myocardial force of contractility. So ACE inhibitor is number one choice if the patient suffering from hypertension with heart failure. Left ventricular dysfunction, that patient has developed left ventricular hypertrophy. We have already mentioned it has cardiac remodeling property. So patient hypertension with LVH, left ventricular hypertrophy, it should be a drug of choice is ACE inhibitor. Type 1 diabetic nephropathy. The main feature of the nephropathy is microalbuminuria or overt albuminuria. ACE inhibitor decrease the intraglomerular pressure and decrease the proteinuria. So ACE inhibitor has renoprotective activity. So it is the drug of choice in case of type 1 diabetic nephropathy or any type of diabetes. Possible indication chronic renal disease, type 2 diabetic nephropathy. If patient suffers from renal artery stenosis and we prescribe ACE inhibitor or ARB, it may deteriorate the renal function. It may so renal function before starting and at least 15 days after starting of ACE inhibitor ARB, serum creatinine should be measured. Caution renal impairment, peripheral arterial disease, and compelling contraindication is pregnancy. Pregnancy, it is highly contraindicated. Pregnancy, ACE inhibitor, এবং ARB, both are highly contraindicated. In case of elective pregnancy, selective pregnancy, uh, ACE inhibitor ARB should be stopped at least 3 hours, 3 months before conception. It may cause renal artery stenosis of the baby. So you have to keep it in mind, and it is better to avoid the omen of reproductive age. If the woman is especially illiterate and she does not know when she will conceive, so it is better to avoid ACE inhibitor and ARB in women with reproductive age. But you can prescribe if you convince your patient that she will not be pregnant, so you can prescribe this. ARB. angiotensin receptor blocker, AC inhibitor intolerance. Intolerance means AC inhibitor, one of its important adverse effect is dry cough, and patient it cannot tolerate this dry cough, and sure you can change it. Type 2 diabetic nephropathy, I have already mentioned in diabetes, the main problem is microalbuminuria or overt albuminuria. AC inhibitor and ARB decrease the intraglomerular pressure and protect the kidney. So, diabetes mellitus with hypertension, AC inhibitor or ARB is the drug of choice. Hypertension with left ventricular hypertrophy is because AC inhibitor and ARB both have cardiac remodeling properties, so you can use this. And heart failure, hypertension with heart failure. Main contraindication of ARB is again pregnancy, I have already told. Beta blockers. Compelling indication of beta blockers is hypertension with myocardial ischemia, myocardial infarction, and in case of heart failure, it should be chronic heart failure and it should be cautiously used, mainly bisoprolol. Main contraindication of beta blocker is asthma, that is obstructive airway disease, asthma or chronic of COPD, and the heart block. Heart block. Calcium channel blocker, that is dihydropyridine means non-rate limiting, amlodipine, nifedipine, etc. Older patient, isolated systolic hypertension, very, very much effective, isolated systolic hypertension, and hypertension with angina. There is actually no contraindication of calcium channel blocker. They can be used also in the pregnancy. Calcium channel blockers rate limiting, verapamil, diltiazem. Main indication, compelling indication is angina, hypertension with angina. Older patient can be used. And there are contraindication also heart block, that is, and heart failure, as because they limit the heart rate. We know heart failure is compensated by increasing the heart rate, that is cardiac output is equal to heart rate into stroke volume. In case in heart failure, stroke volume has decreased, so body will increase the heart rate and try to maintain the normal cardiac output. So you cannot use any drug like beta blocker or calcium channel blocker, that is rate limiting calcium channel blocker. They will decrease the heart rate and heart failure will be exacerbated. Hazard diuretics, older patient, isolated systolic hypertension, and heart failure, you can use this. But main contraindication if they are hypertension associated with gout. So these are the compelling indication of antihypertensive, and it is very, very easy to remember. So this is about something hypertension, and hypertension is very, very important for every student, every physician. We should know details about hypertension. So I have mentioned in brief about the hypertension diagnosis, management. Unfortunately, you cannot tell the normal blood pressure. So it is very much unfortunate. You will always keep it in mind. What is normal blood pressure? In case of systolic, it is 110 to 140 millimeter of mercury. In diastolic, 90 to 60 to 90 millimeter of mercury. So thank you all. Hopefully, we shall meet again in our college campus very soon. Thank you. Bye.